health equity and the future of philanthropy is an opportunity for us to sort of engage and have conversations with leads and heads, leaders of foundations here in Texas who are doing important work in the health equity space. And so as we've done most of this morning, this will be kind of a moderated conversation. We're looking forward to the opportunity to hear from our foundation leaders about how they're thinking about a number of the issues that have been discussed this morning related to the social determinants of health, related to the ways in which we deliver more impactful health services in a variety of different domains and across a variety of different conditions. Each of our leaders here today represent foundations who are very specific and strategic in terms of their initiatives and their efforts and how they think about their philanthropy and the kinds of impacts they're looking to have, certainly across the state and elsewhere. And so with that, we will engage in a bit of conversation, and then we'll leave some time at the end for you to offer questions and perhaps respond to things that you've heard here today. Much like what we've done, we want to encourage you to take notes and populate the idea board here. Really excited about what's emerging here. But again, we see this as a way to sort of extend this conversation, and something that a number of you have said to me is that, when is part two? And so we do certainly plan to do some synthesizing of today's conversations. So all of the information that we're capturing, notes that we're taking, insights that you're helping us generate, all of that will be sort of translated into some summary reporting, some synthesis documentation that we'll be sharing with everyone here. And hopefully by the end of the day, after the breakout sessions, we'll also have some interesting ideas about how we might proceed with some next action items. And so, as we've noted, one of the sort of main drivers of us planning this event was really to be more solutions-oriented. And so that's something that we really want to continue to emphasize throughout the day. It's not only sort of stating and trying to define the problem space, or spaces, but also thinking about, where there's opportunity for intervention, impact, transformation. And so that's something that we're certainly interested in today and beyond. I'm happy to say that we have on our panel, Joe Carcedo from the Episcopal Health Foundation, Reagan Moffitt from the St. David's Foundation, and Kevin Lambin from TLL Temple Foundation. And maybe one way to open the conversation with each of you is just to, if you could give us a little bit of perspective from your foundations, how you define, think about, discuss the issue of health equity, and what it means for you in terms of the work that you do and the ways in which your organizations sort of adopt your positions and then strategically the work that you do.
Is this on? No, it turned on. No. Okay, that's a big question. So we actually spent a lot of time being very deliberate about that question for a couple of reasons. One, we see ourselves as a philanthropy, but we also see ourselves as part of the community, not just the nonprofits that we fund. We are organized as a public charity. Grant making is probably the biggest thing that we do, but we also have a division of research, innovation, and evaluation, and we have a division of community engagement and congregational engagement. We're supporting organization of the Episcopal Diocese, and so our service area is the 57 counties of the Episcopal Diocese, and we've now got 20 more. So it goes all the way from Matagorda, all the way up past Tarrant County and to east of there. But I think in part because we are part of a church of which equity is very important to them, and a lot of this work that is informing the rest of our operations actually started on that part of the organization where the Episcopal Church, under the leadership of Bishop Andrew Doyle, made an explicit decision that the church, as it relates to health, would be outward focused and beyond just trying to get a nurse at the parish center. And so they have spent many years. We were chartered in 2013. We've been operational since 2015. And the congregational engagement piece has spent all of those 8 or 9 years developing racial equity and racial justice as part and parcel of what the Episcopal Church would do. And so we have adopted that in the other operational parts of our organization. The definition that we use is the one by Paula Braverman. Some of you may be aware of that. And it basically says that health equity is where all people have access to opportunity, regardless of race and other conditions, and that they should also, by addressing that part of justice, that we are also looking at what are the reasons that have conditions that support health inequities. And so we're moving from sort of that global statement and understanding. For us, what it means is really being focused on eliminating health disparities, which is a big thing because there's lots of them. And what is the play from the role, from a philanthropic role, as a partner with communities, as a resource to communities, and also a convener and someone who listens to communities in terms of what that exactly means. And lastly, I will say we started that journey really inward focused because we believed very seriously that we could not expect or have conversations with grantees and others that we work with about health equity and racial justice if we didn't shine that light on ourselves first. And so we have taken a journey. All of our staff is involved in this. The leadership is, the organization is involved in it. The leadership of our board of directors is also involved in this in terms of really grappling with our own implicit biases, our own particular perspectives and viewpoints, particularly in a philanthropy that comes from such a place of privilege. We exist on the outside of, by and large, legislation that's not related to the tax codes, except for that. We're responsible to a board of directors. Led by the bishop in our instance, but beyond that, we have certain freedoms and we have certain latitudes to do what we do that are really just responsible and accountable to ourselves. And we take that role very, very seriously because we understand that we are working on behalf of and with communities on something that's bigger than ourselves.
Hey, y'all. Good afternoon. I'm Reagan. I work for the St. David's Foundation and was doing some vigorous head nodding to my friend Joe. I'll say that for us, health equity is that where you live or what you look like doesn't determine your health outcomes. So your race, ethnicity, gender, zip code is not determinative of your health outcomes. And we talk about health equity as not only being an outcome, though, but about a process. And so I think speaking of processes and history that leads you to a place, we really emerged almost 100 years ago when a small group out of the congregation at St. David's Church down the street from us said, we need more access to healthcare in our community, and created what is the seed of the current St. David's Hospital. And the foundation was created out of the sale of a portion of that hospital. And so we use those proceeds as well as assets from the hospital distributions each year to contribute to our community. And I think our journey as a foundation has been really staying pretty true to those roots and really funding around health. And we still do fund a lot about health, but there's also a recognition that you can't just fund health care without looking at the whys and really getting to what are some of the root causes of these issues. And so that journey for us has been first to look outside of the walls of clinics and to start to talk about social determinants or non-medical drivers of health. And a slow journey, very slow journey. And then I think to begin to talk about health equity, but to really wedge it in the center to the moment we're in now, where we have centered it in our mission statement and it is core to everything that we do. And to tap on to Joe, I think one of the things we realized is that we were really eager to start doing this externally out in community. And yet, if we don't engage in this journey internally first, and I think that we have a lot of work to do, and we're in part of that process right now. So there'll be more time to share, so I'll leave it there. Pass it along.
What they said? Yeah. No, it's great going last because, they set the foundation for that. I'm Kevin Lambing, and I am the Senior Program Officer for Health at the TLL Temple Foundation, located in Lufkin, Texas. And we work very closely with both St. David's and the Episcopal Health Foundation in a lot of work that we do. When Craig asked the question, he sent us some questions in an email previous to this, and he said, how do you define health equity? I didn't have to think about it because as the Senior Program Officer for Health, every day, my goal, my mission statement in the strategic plan is that all East Texans are healthy and have access to quality health care. And so the work that I do each and every day is around that everyone in the 23 counties in Texas that we serve and the one county in Arkansas that we serve are healthy and have access to quality health care. We've been around since 1962 as a family foundation. Mr. TLL Temple started the Southern Pine Lumber Company in Texarkana in 1898. He failed twice, but on the third time, he got it right. And in the early 2000s, the Temple Inland Company sold for about $40 billion. So don't give up if you fail twice. Keep going. You got it out there. We're actually not a foundation based off of the business, however. We are a foundation based off of Mr. Temple's daughter, who set up a foundation in her father's name. And we fund basically in 4 areas: health, human services, education, and economic opportunity. And I think it's great what you said there, Reagan, because we can go after health care. But in our foundation, a number of times, the person whose problem I'm trying to solve in health, my colleagues are also trying to make sure that the school that child is going to has what they need, that the parents of the child also has economic opportunities, and the human services are available for the family for those wraparound services. So it's a collective. And I would say this morning was a really good session, and there are a lot of really strong personalities here and thought process here today. So would you all just be interactive with me for just a moment? How many people here are visual learners? Wow, that's not a lot. How about hands-on? Are you a hands-on learner? Can we stand up just for a minute? Will that be okay, Craig? Yeah, it's your deal. So if we could stand up real quick.
It's probably a good thing right after lunch.
It's right after lunch. If you're the speaker right after lunch, in about 20 minutes, your tea's going to hit you, all right? Then the insulin's going to hit you. Okay, so let's be interactive. So here's what I've seen so far this morning, and I hope you have too. Do me a favor and just put your hands down to your side. And just cross your arms naturally. Just naturally cross your arms. Oh, that feels so good, doesn't it? Oh, you want to nap right now? Okay, back down to your sides. We'll do it one more time. Just cross your arms really naturally. Oh, that feels so good. Okay, back to your sides. Now, when I say three, you're going to cross your arms the opposite direction. 1, 2, 3. Oh, wow. Some of y'all, I don't know. All right, have a seat. You did a really good job of that. Yeah. So that does 2 things. First and foremost, get your blood going, but also, did it make you feel a little bit uncomfortable trying to go that opposite way? And I think that's what we're trying to get at here today, right? We're trying to get you uncomfortable to think, do, and fund in this area. And I think that's what the mission of IC Squared is about.
Absolutely. Yeah, no, thank you. Thank you for the wake up right after lunch. We needed that. I know I certainly did. I know a little bit about each of your respective organizations, a little bit of your priorities, and know that the health equity space isn't necessarily a new space for you, that you each have been thinking about this space for some time. I know you're relatively new in terms of just the duration of the Episcopal Health Foundation in terms of its existence. But even given, right, your own sort of historical sort of engagement with health equity and a lot of the sort of intersecting issues, we know that a lot of external factors over just the last 3 or 4 years or so, COVID-19 being an obvious one, social unrest, what we're learning about the increasing kind of growing economic inequality, that a number of philanthropic foundations, and I think a lot of people in this room, researchers, development officers, practitioners, have also felt the need to respond, right, to what many of us might define as sort of a set of crises that have hit us relatively hard. And it's compelled many of us to sort of think differently, to ask different questions, to sort of think about how can we perhaps engage in activities that deliver more impact. And I'm wondering from a foundation's perspective, how have some of these external factors and drivers sort of changed your philosophy, your strategy, your investments in terms of how you're thinking about health equity in the face of COVID-19, in the face of growing economic inequality, in the face of social unrest?
I think because we're a health philanthropy, we don't fund anything else, and we are also data-driven. I mean, we just can't look at the health status outcomes of virtually any community in Texas and not ask the question about why these things exist. So I think the data force us to go upstream in our work. One of the panelists, Minnie, made a comment about earlier this morning about where the money is. The money is in the healthcare system. We're well aware of that to the tune of trillions of dollars. And so part of our mission was to really figure out ways to move that money from that part of the system so that it could fund those conditions that we've talked about all morning around non-medical drivers of health, which is a political term you probably know as social determinants of health. But anyway, story for another day. And so what it forced us to do was really get serious about these following things. Number one, it was not just understanding what the data were telling us, but it's also understanding the people behind the data. So, and being in relationship with the communities and the nonprofits that we serve. The second thing that it forced us to do was to look at sort of two approaches. One is at the systems level, because the healthcare funding and financing is a systems level issue. And so we look at that from working with communities and nonprofits to engage in advocacy. We actively lobby for that. We work with particularly community health centers in a very aggressive way as anchor institutions. We typically think about that as hospitals, but for us it's really the community health centers. As part of the promise of changing the conversation and changing how the system works. And the other thing is, and part of what we're challenged by in Houston, when Episcopal Health Foundation started, all the other philanthropy sort of backed out of the health space. So we've got this like systems thing going, but somebody's got to pay clinics to keep the doors open, right? So we do direct services as well. And what we're trying to do is really figure out how to marry those two together where all boats rise, meaning that we're building capacity of our clinics and our other grantees within our space, and we're working to build their capacity to participate in that ecosystem that either supports them or denies them the kind of support that they need. I would also say that the other driver, I think the other sort of crises for us beyond notable murders that occurred was really for philanthropy what has happened in the market. So as the corpus of foundations is being challenged because of market forces and you have potentially less money, then how do you spend that money and where can you be most effective in creating solutions with the communities that we serve?
You sure you don't want to go first? You could cross your arms the other direction.
The last shall be first.
I will say a few things. So my wonderful colleague Apana is in the room, and I really joined the foundation when we were in the midst and moving through some of the moments that you're describing. And I think, and I'm looking to her to nod vigorously or to say, Reagan, don't say that, is that I think it was a reality check for us about what we thought we were doing and what we were doing. We were saying a lot of things like, we can't. And during the pandemic in particular, we did. And so it became really difficult after the pandemic to say, we can't. Because we did. And so what is it to take some of those things we did, allowing general operating support, more flexibility, more nimbleness, more folks coming within our walls. We've been invitation only for a very long time, and actually allowing in folks who wanted to come within our grant portfolio. So I think it changed what we could say we could do and we couldn't do, and showed us we could be more flexible and nimble. I think it also showed us that, good work is important, but work that's proximate to communities is maybe more important. And that when we actually saw what needed to happen during the pandemic, our relationships were up here instead of down here, with some rare exceptions, so largely through our rural portfolio. And I think we realized that in particular, we were not funding BIPOC-led organizations en masse, and really taking note of that and saying, gosh, we need to change in some significant ways. And I think that what I said earlier about health equity coming to the center of our mission statement, to being really core to what we were about, really was accelerated by the moments that have happened over the course of the past few years. And I think some of the things we tried, maybe thinking that they were temporary, realizing that this has really got to become core to who we are.
I think for us as a foundation, I mentioned we were started in 1962, and probably over 5 decades, we were a responsive grant-making organization. That's what we did. You came to us and we said, sure, we'll fund that. We had no strategic plan or weren't really looking at any return on investment. And so in 2016, we had our first strategic plan. And then in 2021, we came up with our second strategic plan. But I think what happened in the midst of the COVID-19 pandemic and some social injustices that came to the forefront in our country is you have one of those photos that you go back and you look at, and it's your wedding day, and now you're 25 years later, and you look at it, and you see yourself every day in the mirror, and you go, oh yeah, I haven't changed much. But then you look at that photo from 25 years ago, and you go, wow, look at that, yeah. Am I still on? Yeah. Well, I think that's what we did. I think that's what we did as a country. I think that's what we did as a foundation. I think we looked at the fact that we thought we had it all figured out, and we just kind of went with it. And, oh, yeah, we're doing fine to address this, to address this, to address this, to address this. But, wow, when we really looked in the mirror, we said, wow, as a country, as a foundation, man, we've really kind of let things go, and we got to refocus ourselves on that. So in the midst of the fact that we were just going to be a strategic grant-making organization, and we were only going to fund systemic change, and we were only going to make sure that we got a return on investment on every dollar that we put out there to our rural communities, COVID hit. And we had to say, whoa, we're going to have to pivot here and kind of go back to readdress some of those core things that we need to address and set a foundation before we can make some of these strategic plans and initiatives that we want to do. We know that rural East Texas and rural communities across the country lose out on millions and maybe billions of federal dollars every year that should come down, that are enacted by law, by legislation, and are earmarked for rural communities, but they don't quite get there, right? To an old phrase says that you're feeding the horses to feed the sparrows. Some of you will get that. And so what happens is the dollars are well intended to go to rural places to make change, to go to great programs to make change, but they're fed into these big systems and never get to the grassroots of where they need to go. And so we're excited to work along our partners, but also partners with, Lillian's going to hate me for saying this, but Lillian Salerno, who President Biden named as the Texas Director for Rural Development from the USDA, is in attendance here, and we're working with great partners like the USDA to find out how we can be a part of the Rural Partners Network to draw down these federal dollars to make the most change that we can, because we as foundations and as philanthropic organizations, we can't fund our way out of this with our dollars. We've got to come together as communities to draw down what we can to make this happen.
Yeah, no, it's a great point, and it's a nice segue into the next question. So, as we all knew before this event today, health equity is a big topic. the various conditions that we're facing and trying to address are massive and expansive. Foundations have limited resources and limited capacity, as we all do. I wonder if each of you could talk a bit about, are there specific areas of health equity, health conditions, mental health, chronic disease, are there specific social determinants of health, right? Because there are many social determinants of health, non-medical drivers of health outcomes. I suspect, right, that as you think about your priorities, your investments, that you have to perhaps be a little bit precise in terms of how you target, your resources. Could you talk a bit about how you're thinking about targeting those resources and what areas for you are resonating as most important?
Actually, we weren't. So when we first started, particularly on the grant-making side of the operations, we really relied on communities. So we had these broad goals and objectives in terms of what we wanted to accomplish per, health. And then we really relied upon principally nonprofit organizations to sort of define for us what that looked like for them in their communities. And I think we built some things as a consequence of that have really taken root in some organizations and communities, but we really didn't build things that were sustainable in the long run. And so now I think that we've become more precise in our thinking and addressing, again, moving from health equity sort of as a broader conversation into health disparities, which really allows us to look at specific conditions and specific diseases to be able to focus on. And I think retrospectively what we look at, what we've invested in, particularly with community clinics, there are three areas that emerge for us. One is maternal health. The second one is food systems, and the other one is diabetes. And so we will actually sort of expand what we do in working with some unusual suspects in terms of, for some of that work, initiating some place-based initiatives, which for us is new as a philanthropy, to really have that solution in part be fomented by the people who are experiencing these conditions, but also have resources. Earlier in the conversation this morning when we talked about data and the sharing of data, communities have data. The organizations that work there have data as well. And I think we've relied heavily on the data that comes out of the healthcare system. And we're actually beginning to move in ways that incorporate that experience of what the community understands and knows for itself. So I think in terms of particular conditions, we'll probably, in our new strategic plan, focus on them in a deliberate way that we had not in the past.
Where to start? It's a good question. So I will say we currently organize our work across 5 goal areas. So 3 of them are the lifespan. They're very easy to remember. You'll go home knowing these. So resilient children, healthy women and girls, older adults, aging in place. And then 2 that we call our levers, thriving rural communities and clinics as community hubs. So I might start with the 2 levers because it's taken really kind of different approaches to it. So with our clinics as community hubs, there's this idea that clinics are providing healthcare services and important and critical, but are they thinking as a system about the other factors that the clients and families that are stepping into their walls have, and can they be a connector, not have a brochure, but actually be a warm connection to the services that are needed. And it won't surprise you to know that it's harder than you think, because for systems that are built for one thing, to tell them they ought to be something more, it's change management 101. It's the resistance of the system to shift. And then I would take thriving rural communities as the opposite, which is Abena and reaching out to communities and saying, let's talk about health. They say, sure, but let's talk about broadband first. And let's talk about the fact that there's no jobs in my community. And rightfully so, our Thriving Rural Communities portfolio moves to health through what is actually impacting the folks who are on the ground every single day. And so I think that both of these bodies of work have been teachers to us about, if we're going to do this work, do we work with systems and try to get systems to shift, of which, in our heads makes a lot of sense. We can reach many more people, but if those systems are highly resistant to change, or do we work with people and know that we're going to have a lot less say over what is the actual needs are? And I think part of what the teaching is, it's both. We really have to think about both, and how do we as foundation service connectors. The only thing I'd add more broadly is really starting to see this as a continuum. You've probably seen the graphic before about downstream, midstream, upstream, and I don't think we can choose a place in that we really have to see that people's immediate needs have to be served, and there are challenges that we must address. But in the midstream, really saying, okay, so let's start to think about what is the totality of the humans we're talking about, and then going upstream and changing systems. And I think that none is better than the other, in part because the time horizon of each is really different.
It's great, the similarities that all three of us have in the work that we're doing in this space. And as the Senior Program Officer for Health, my two lead strategies are in my access is provider availability and access to affordable health insurance. I'll touch on that just a minute. But, as I said earlier, we have some other funding areas with the foundation. And so literacy and numeracy are big pieces of the puzzle for the education side of our foundation. In our rural counties, we have 22 rural counties. Harris County is in our region, but it's a big urban area. But in our 22 rural counties, only about 35% of children are on third grade reading level. Why is that important? Well, we know that you learn to read from kindergarten to third grade, but you read to learn from the third grade on. And so a child that's not at third grade reading level is probably 60%, 62% of children that are not at third grade reading level do not finish high school. And only about 10% of them matriculate into higher education. And so it's a very important data point to take care of. So on the education side of the house, we're really looking and focusing on numeracy and literacy to have thriving communities. Food insecurity is a really big thing for us over in our region as well. So we work with 5 regional food banks and over 200 food pantries in the region to ensure that people have access to fresh fruits and vegetables. We've kind of looked at that on the health side through our food banks in their Food RX program, where we work with our federally qualified health centers and the food banks in the region to ensure that those patients that have hypertension, hyperlipidemia, or diabetes, and the physician says they need more access to fresh fruits and vegetables. But I'm sorry, they cannot go down to the bougie H-E-B market and get that because they can't afford it like I can. I'm privileged to be able to do that. So we need to give them a way to get some of that. And so when they come for their appointment, along with the prescription, they also get a ticket to go. When I go to the food pantry, I get an extra 10 or 20 pounds of fresh fruits and vegetables on top of everything else that I can get. And so we're trying to improve the access that way. So health, how are we doing it in health? Well, we have a big shortage in providers in our region. Newton County, Texas is the longest county in the state of Texas at 90 miles long. It's home to 15,000 residents, and it does not have a single healthcare provider in the entire county. This is 2023, and they don't have an ambulance service in their county. The county adjacent to them is Jasper County, and they only have an ambulance service in half of the county. And so as we look at things like maternal morbidity, 24 counties that we serve, 14 of them have no labor and delivery. We used to say that there was no place for women to have babies, but we knew they're having babies somewhere, right? And so if an under-resourced family with one car is in Newton County, Texas, and part of the answer for most big health systems is we'll just schedule a mom for the delivery. Well, that's great, but babies don't wait for you. And so you can schedule a mom for Friday, but on Wednesday her water breaks, and I live in Newton County, and my husband works at the plant nearby. He uses the only car that we have to go to work. Oh, by the way, we don't have broadband. We have bad cell service, so I'm trying to get a hold of an ambulance that doesn't exist in my county. So you see where I'm going with this. And so we've got to address those core issues for access to care. And then, of course, Texas, we're holding out. We're now one of 10 states that haven't expanded Medicaid, right? Because we know this year that both South Dakota and North Carolina both put it on the ballot and to pass it. But we're going to hold out and make sure that our people don't get covered. So we're doing a lot of advocacy work around Medicaid expansion, but we're also doing a lot of advocacy work around Medicaid in and of the current programs that we have. Why can't we give moms 12 months of post-delivery care so that we can help to try to decrease those maternal morbidity rates and mortality rates that we have, especially for African American women who have the highest rates in the state and in the nation?
So I have a couple of questions, but for time, I want to defer and give you an opportunity. Any questions, responses in the audience? You have one here, Brett.
You're going to get it in now, aren't you?
Yeah, I am. Thank you. So I have you guys talked a lot about what you're funding, so health equity and stuff like that, but my question's around who you're funding. So last month, a study came out on NIH funding and who they're funding. 4,000 of them, of the people, 11% of the people that they funded in the last couple of years are what they called super PIs. So they had 3 NIH grant funded for about $1.3 million. Of those 4,000 super PIs, 3,000 of them, 75% are white males. Of those 4,000 super PIs, 12 are black women. And so it's not, I guess my question is, what is your strategy on who you're funding? It's not just what you're funding. Who is studying us now?
I can start since I'm holding the mic. I'll pass it on. I think knowing is the first key for us. So we are actually tracking that now. So we can't do something about it unless we know it. We have, during the course of this current strategic plan, had a specific approach within our women's health portfolio about funding Black women-led organizations. And so, again, better than tracking it is to name it as a specific goal. But it's only women's health. You just heard all of the other puzzle pieces. So I think we acknowledge that we have a long way to go, and yet I think some of the puzzle pieces for us and probably for other funders is to know and do, but then to really hold ourselves accountable.
So it's a great question, and I think I'm going to go back to my comment earlier about how we were just so comfortable in what we were doing, and then all of a sudden we look at the wedding photo 25 years ago and see how much we've changed. We have to start looking. Jo and her team put out some amazing data. They study things, and it's so amazing what the Episcopal Health Foundation does with their data. Well, data's great, and if I just look at data and I don't do anything with it, and if I don't disaggregate the data. See, we look at health outcomes, we look at things that we funded, things that we don't fund, and we look at, if we just look at the top number of data and don't disaggregate it and go down and see that there's only 12 Black women that are being funded, then we can't really make a change. We've got to look at the disaggregated data. So one of the things we did with our food insecurity is we looked at our census tracts. Where are the communities? Where are the communities within the community that really need the most help? And so we have started funding resource centers in those regions of our under-resourced. And I'm going to say it: most of the under-resourced regions of our communities are people of color. And so we have put a significant effort into putting the resource centers into those regions where we have a client choice pantry, which brings pride to people. And if you don't know what a client choice pantry is, sir, maybe you don't like peanut butter, but every time you come to the pantry every week, I hand you a box with peanut butter in it. So you have 10 bottles of peanut butter at your house because you don't eat it. right? A client choice pantry is where the person comes in, they get a buggy, and they walk through, and they pick what they like off the shelf. They make the choice of what it is. And it also brings pride to the person as well. In the Resource Center, we have rent and utility assistance. So whenever you first come in, we screen you for some services that we have, and we'll say, you need rent and utility assistance, we can get you with the Greater East Texas Community Action Program. I see that your child is not signed up for CHIP, or Medicaid for Children. We have someone there to navigate you there. We have a SNAP application person to do that. So, and the FQHC is a mile down the road, and they come and they do health screenings. And during the open enrollment period, we have a navigator there to help people walk through the enrollment process. So, looking at the disaggregated data, identifying the regions where we need to do the funding to make the change is what we're doing.
I would also add that we have started being very intentional about collecting data on who we serve. So out of our grantees, there are about 140 of them. I believe it's 46% of the leadership identify as people of color, and then 64% of the staff identify themselves as people of color. But I'll say a couple of things about that. We prioritize our work where poor people live, of any color. And because of the organizations who are very mission-driven in those areas, they tend to reflect the communities that they serve, which is why that number, frankly, was higher than what I thought it was, because we weren't intentional about what it was, but we were intentional about working with organizations that had the closest touch to people who were under-resourced. And I think it's important to disaggregate data, but I think we have to be careful about it in this sense. We're disaggregating data on people who have been marginalized. Racial justice and health equity impact white people as well, and there's virtually no data on that. And I think if we see ourselves as part of a community, then I think that we have to look at everyone who is in that community, particularly in terms of where the resources are. We're going to move into a place-based strategy because it sort of is an easier way of identifying, oh, well, let's go to this organization because, they're Black-led, or this other organization because they, have Latino, and look at the place and who is in there. Because if we believe that the solution to problems is owned by the people who are there, we need to be able to work with everyone and understand from their perspective what it is that they're trying to solve for and who needs to be at the table while solving it.
Hi, I'm Lillian from the federal government, and I'm here to help. But I just thank you, Kevin. But one of the things we have such a challenge is we are also, as federal agencies, recovering from COVID and how to respond. And for the rural part of this state, we're in real trouble. Right. So I was in another administration, not the last one, but the one before that. And when you'd go to rural America, and I traveled a lot in Texas, but across the country, you'd hear, I want a septic system, I need some sidewalks, I need some broadband always. We're addressing broadband, it's going to happen. Okay. Not us, but the Department of Commerce. But now you hear rural mental health everywhere you go. I mean, I've been in rooms in West Texas, where everyone there is packing a gun, and all male and all white, and the stories they tell of what they have to go through as small towns in West Texas because they have to take people 8 hours in their police cars, which they can barely afford, to go to a mental health facility. What people go through and how Lubbock dumps people in when they take overdoses, because Lubbock, in their minds, the big city, puts out in their town so that they have to pay the costs. I mean, the stories are just horrific. In West Texas and East Texas, I do think that I give a shout out to TLL Temple Foundation because I do think that having monies from foundations and others that can help with technical assistance, we don't do that well as the federal government. We don't know how to do that because Congress won't let us give monies to Aunt Sally to go to the city secretary and fill out an application. It just doesn't work like that. You have to have people that help people fill out applications for the federal government. If I'm in the city of Dallas or at Harris County, I've got a Deloitte contract or this contract or a grant contract, and I can fill out an application to get federal funds. If I'm in Smithville, Texas, I'm the city secretary. I've been here 25 years. I manage everything. I don't have any time. I have capacity because these gals are running this state, quite frankly, the small town city secretaries. But they don't have time to go and fill out an application to get the $80 to $100 million that we'll leave on the table in Texas this year because small towns won't access the funds. We invest almost $2 billion a year into Texas. Year after year, we send back $100 million. And it's really hurtful as a Texan to see that money go back. And that's why I came back home. I'd like to change it, but we're going to need the foundation's help.
Yeah, can I just say one thing real quickly about rural? It's almost like we just discovered them. The majority of this country is rural. And I think if there's an equity issue at all, it's about rural communities because they're by and large ignored by philanthropy. And to your point about public funding not being able to be drawn down by those communities because they don't have the resources there. And I guess the good news is that we've discovered them, rural communities, and now that, we're sort of here from philanthropy and we want to help them too. But, I think that we just really need to start thinking about the resources and how they're deployed, and also understanding that rural is not just a geography on a map. It's a state of mind. It's a culture. And to work in communities which we don't have a history, they're not collaborations, there's not a level of trust, it's going to take time for us to be able to do that and build that. And quite frankly, it's going to take us time to be able to address health disparities and health equity. That problem did not happen 3 or 4 years ago. That problem has been accruing over decades. And so I think all of us in here have to have the long game in mind for this. I think our resources do need to be leveraged with federal dollars because, quite frankly, philanthropy and nonprofits have been tasked with backfilling what government should be doing. And I think all of us need to hold them accountable for that money that should be in Texas. But there are structural barriers and political viewpoints that don't want that money here. That money builds infrastructure in ways that philanthropy will never be able to do. And I think that we need to advocate for bringing that down. I think philanthropy needs to leverage that money, and we need to start building capacity in those areas that we have by and large ignored for years.
Unfortunately, as with all of these panels, these conversations could go on all day. So we have to stop here and transition to the third and final panel of the day. And we have a lightning talk preceding that. So thank you so much.